also have 2 handouts for you. It's Fountain Valley's nursery flow sheet, and I just want you guys to have that, okay? Any questions from yesterday? Any pressing things? Contract, can you sign that and then pass those up? Okay. Have any of you used clickers in any other previous classes? Yes. Did you like them? Yeah. No? Okay. We've had really positive feedback. They actually, some courses will do quizzes with clickers. Because it tracks. Like, I can go in and see all your answers if I wanted to. It's pretty cool. But we're not going to do that. We're just doing it for like sugar. We actually got them because students, who's the president of this class? Oh my God. Monica. So Monica's the president, and then if any of the other officers come to faculty meetings, we actually use clickers now because of the feedback we receive from students in our faculty meetings. They requested that we get clickers. So that's how it all came about. Yes. Awesome. Thank you so much. Okay, so I'm going to call your name for attendance today, and then when I call your name, you're going to define a vocabulary word. All right? So, and I'm not going to go down the alphabetically because then you're going to know that is time. So be ready. Okay? Okay, let's start with Janet. What is EDC? Okay. It's the due date. So it's the estimated date of confinement, but you're going to hear EDC. When a patient comes into L&D, we're going to ask them, what is your due date? We're not going to ask the patient, what is your EDC? They're not going to know what we're talking about. But in nurse-to-nurse communication or nurse-to-physician communication, this is the current terminology that's used. What is her EDC? Whenever a patient comes in and she doesn't look full term, that EDC is really important for that patient to know. Some patients have no idea when their EDC is because they have no idea when their last menstrual period was for a variety of reasons. They just had a baby, they were breastfeeding, they never started having periods, that's one of the reasons. Some women have very irregular periods. So then we would fall back on the ultrasound to determine a due date. Early ultrasounds are very good at helping us determine the due date. So that's something just to keep in the back of your mind. If the patient doesn't know the EDC, our next question is, well, did you have an ultrasound during the first or second trimester? Because that's when they'll be very accurate. Okay, so very good, Janet. Vanessa, what is an LMP? Yes. So our LMP, and that's what we regular cycle, they know when that LNP was, that's actually the best way to determine the EDC is knowing their last menstrual period. And that's the first day of the LNP. We go 40 weeks from that day. So that's how it's determined. Okay, next is Lou. What's a gravida?
Gravida, the woman who's pregnant.
Yeah, so every pregnancy counts in the gravida. Okay, so no matter how many times she's had miscarriages, some patients have a lot of miscarriages, and they have what's called an incompetent cervix, and they just lose a lot of babies. So all the pregnancies, including the current one, okay, that's how we get our gravida. Okay, Rod, what's a para? What's Rod?
The number of birth cycles from each patient is always stated.
Right, so 20 weeks and beyond, that counts stillborn babies, if they've had stillborn. A para would count multiple pregnancies, so multiples are like twins, triplets, quadruplets, quintuplets, and octuplets. Okay, so any pregnancy that gets up to 19 and 6/7 weeks does not count. And that's how we count. I used to have my little pocket thing I'd always have at the L&D nurse, and it's a little EDC LNP calculator of how many exactly gestational weeks the patient is. Because I was a high-risk nurse. So I have that. I'll try to bring one of those in. I still have one of those. But they're great to have when you're a labor delivery nurse. So you can actually calculate it out yourself. Okay, next is Anne. What's a primat?
Easy to track pregnancy hormone because there goes a parameter.
Right, so that's our patient coming in to deliver her very first baby ever. Primat. You're going to hear that term a lot. Let's see, number 6, Joaquin. What's a MOSA?
Indicator for pregnant mothers before birth.
What? I can't hear you. Say that again.
There's nothing to do with a second child.
Second child and beyond. So second through the 19th. There's a family on TV that TLC, right? 19 and counting. Yeah, they're kind of crazy, but the children seem really good. Okay, so second and on is a multi. Okay. Let's see. Number 7, RON, Julie.
Which one?
Rude. Is that right?
Rupturing of membrane.
What?
Rupturing of membrane.
Rupture of membrane. So when you see RON, one thing I don't have on this list is ARON. But you're going to see this too. So ARON is another one, artificial rupture of the membrane. So that's when the doctor breaks the water. Right? It happens a lot, unfortunately. That's usually when we get into trouble, depending on when they break those bags. It's the rupture of the membrane. That's the amniotic sac. Okay, knowing these are interchangeable terms. All right, okay, Rebecca, how about number 8?
Inside the bag of water.
Yes, and how did you find out?
I called the OB department and found out.
She called the OB department at Fountain Valley. That's genius. Because I basically made this list from the L&D standpoint of what you're going to hear when you're in a unit. So she was very resourceful in just calling up, hey, what does this mean? I'm sure you got...
Yeah, we worked together with
Right.
transporters and stuff.
Yeah,
So.
so she's a dispatch, right? You work in dispatch?
Yeah, I also do transporting over there too.
Okay, so transport patients
We're
too.
contractors.
Okay, yeah. So
we
she
see a
knows
lot
the
more
unit.
people.
Yeah, that's awesome. I just thought that was very resourceful on her part. Okay, you got this. Okay, number 9, Monica.
A spontaneous rupture of membrane.
The spontaneous rupture of membranes is when the water bag breaks on its own. And that's preferable, is when it just ruptures on its own. Good. Okay, number 10, Regina. Oh, she's not here. Janine.
Premature rupture of membrane.
Right. So premature rupture of the membranes. You might also see PSRON, premature spontaneous rupture of the membrane. But just so you know, it's premature. It's prior to 37 weeks. Okay. The water bag breaks at 37 weeks exactly. Now we're full term. But at 36 and 6/7 weeks, that's considered premature. Okay, that's a late preterm baby, 35 to 37 weeks. So understanding premature to what? Premature to that full term time. Okay? Okay. Porphyrio, 11.
Uterine contractions?
And do you want me to call you Junior?
I don't want it. Whatever you do.
P-Dog?
Or Robin.
Or Robin? Okay, I'll call you Robin. Okay, so UCs, you're going to see that a lot, that abbreviation for uterine contraction. Okay, that's really common. And when we're measuring the uterine contraction, what are we actually measuring? Frequency? Okay, so frequency, how do we measure frequency from what to what?
Beginning of the first contraction.
Yeah, beginning from the one, the beginning to the next, the beginning of the next. It's really important to understand that. Okay, and then what else? What? How long they last, right? How many seconds? And each little box on that strip is 10 seconds. So we basically count those little boxes and multiply by 10, and that's how many seconds the contraction lasts. And then what else? The intensity. And how do we figure out the intensity? Palpating the fundus with what? Fingertips. Okay, the tips of our fingers go to the very hardest part, which is called the fundus of the uterus. So those going to L&D on Tuesday, I want you palpating contractions with your nerves. And do that on as many patients as you can. Some patients who are really thin, you can palpate the contractions really easily. If a patient has a lot of adipose tissue, it's a little trickier. But it's best to do that when the patient is on their side. Okay, so please do that. Number 12, and that's Norma.
Fetal heart rate.
Right, fetal heart rate or fetal heart tones. That's what FHR or FHT stands for. So what are we looking at with fetal heart rate? Yeah, the average range is 110 to 160 beats per minute. You want to see acceleration. If we're seeing deceleration, we're not real happy about decels, depending on what type they are. But we'll get into that next week. I'll talk about this so much in the script. And we want to make sure there's fluctuation in that baby's heart rate. If there's a straight line on the fetal heart rate, that's an ominous sign that this baby is not alive. Okay. So we want to see a strip with lots of fluctuation. That's what we're looking for. Okay. 13, Trisha, what's dilation? Right. It's the opening of the cervix during labor. And it goes from what to what? How many centimeters to how many centimeters? Right. It starts at 0 where it's closed, and it goes to 10, which is completely dilated. Very good. Okay, and then Julie Wen, what's replacement?
Cervical thinning.
Right. Right. And it's a thinning of the cervix. It's measured in percentages. Very good. Okay, Jenny, what's station?
Measurement of the fetal descent in relation to the ischial spine.
Very good. Yeah, so station is determined by the fetal head descending through the pelvis in relation to the ischial spine. When the vag exams are done, 2 fingers go into the vagina. They're palpating around that head to feel those ischial spines. And we go in relation to where the ischial spines are and the top of the baby's head. And when you do that a lot, you get really good at it really quick. But it takes practice. It's one of those things that takes a lot of practice in nursing. Okay. Number 16, Hans, what is vertex? Yes, the cephalic presentation is the most common. It's the one we really want to see of the vertex presentation. It's cephalic. It's the baby's coming head first. Very good. Okay, and then number 17, breech van. Actually, the baby's bottom, baby's gluteus maximus, or the feet. Yeah. So baby's coming longitudinally, but the wrong direction. So we have the feet and the baby's bottom coming down first. typically that's going to be a stat C-section. If it's a known breech, it's going to be a planned, scheduled C-section. And sometimes they come into labor and nobody knows their breech, and especially when they're about 8 centimeters, and they actually feel the baby's anus. That's how they know. They're like, whoa, what do we have here? We have a little baby's butt. Okay, that section. So it becomes very fast at that point. Hopefully we pick up on those breaches way before that, instead of allowing a patient to labor all that time before we discover she's breached. Okay, and then 18 is OP. Jennifer Medina. Right, occipital posterior. And I showed you, and I actually have this slide up to re-emphasize what that actually means. But we're talking about this occipital bone in relation to mom's pelvis. Okay, so babies should be born with face down when they're coming, like patients laying on the bed, the baby should be face down. When you hear that term, the baby's sunny side up, that's another term for OP, occiput posterior. So if you hear your nurse say that, oh no, she's OP, or oh no, this baby's face side up, it's very difficult to get those babies out vaginally, unless she's a mole-set and she's had several babies. My daughter-in-law actually did it with the first baby. It's quite a miracle. So just understanding the occipital bone in relationship to mom's pelvis. We all have a pelvis. I know when I was doing anatomy and physiology, I'd be like, okay, here's my body, here's my bone. So if you think about your own pelvis, you have 2 anterior sides, you have left and right, and you have 2 posterior quadrants to your pelvis. It's that bone in relation to this pelvis. Okay, so just think about it that way. So when this baby is OP, the occipital bone is against her, like the left and right posterior part of her pelvic cavity. So that's going to cause what? Increased back pain. If you look at the diagram, when patients walk in the door and they say my back is killing me, I'm just like, no, it's okay. No, I don't tell her that, but I'm like, oh, you're having a lot of back pain. Basically, their labor is constantly in their back. They're just in excruciating pain. So we try to get the babies to turn. There's nursing interventions that we can actually help these babies to turn, and it's usually very successful. I worked with a nurse midwife who came from Thailand over to America, and she could turn babies really, really well by doing the Baji fan. She could do it better than any of our doctors by just going in and sliding this baby and getting them to turn. It was amazing. She was like, the doctor would say, where is she? Get her in here. Get Tanya in here and get my patient.
That's what they call back labor.
Yeah, so when a patient's having back labor, we want to get that baby to turn. Yeah. Okay, presentation number 19. Is it June? June Kang? Okay. Is that what you go by? Did I say it right? Jamie. I want to write it on here so I don't call you wrong. Jamie. Right, the presentation. So, absolutely. Very good. And then number 20, bloody show. Theodore?
Mixture of the cervical mucus and blood from ruptured capillaries.
Right, so bloody show, patient, and it's a mucus plugs, and there's blood mixed in it. So if you see bloody show, excessive amounts of bloody show, patients can lose that mucus plug and have a bloody show up to a month before they deliver. So it doesn't necessarily mean they're in labor. For primates, because there's a lot happening at the end of pregnancy, the first time they're pregnant, they might lose their mucus plug, they'll come into the hospital thinking they're in labor, and no, they've just had some bloody show, mucus plug. So understand that. When it's an active labor patient and we're seeing a lot of blood and a lot of mucus, that's normal too. And I hope you actually get to see it so you hear what I'm talking about when you're in labor delivering. But bloody mucus is normal. We tell the patient, oh, this is normal. There's nothing wrong. This is part of labor. Okay, we want to reassure them that everything is okay. Okay, with your homework, this is for you to study. Okay, you're going to get another one today, and by next week you should be really good with this lingo as far as me talking about these things. How many of you have been reading in your book? Good job. That's going to be really, really helpful getting into the next one. Okay. So I just wanted to reiterate about the occipital bone. This is what we're looking for in relationship to the maternal pelvis. So you're going to see chart at ROA, right occiput anterior, which is what we love, or LOA, left occiput anterior. These are the two perfect positions for a vaginal birth. When we see ROP, LOP, that's when this occipital bone is coming against the back of mom, and baby's coming out face up. Okay, so this fontanelle, once we get to the newborn, you're gonna want to know these two fontanelles, the posterior being triangular and the anterior being diamond shaped. When you're doing vag exams and you feel that posterior fontanelle, we're happy to feel that. So just understanding that anatomy is really important for you to understand. Any questions about that? No. Okay. Okay, there. And we already looked at these breech presentations. There was just a few things on here that I wanted to cover. Promontory signs of labor. These are signs that usually happen when labor is actually beginning. Braxton Hicks contractions are just false contractions. They are contractions, but they're not causing cervical changes. Okay? So patients who are saying, oh, I've been having lots of contractions, and Braxton Hicks can start happening like when they're 20 weeks. They can start happening in the second trimester. So it's not anything to be alarmed about. What we're looking for is cervical changes. Lightning, whenever we see where the baby has dropped, where maybe you've known somebody that's pregnant and all of a sudden you're like, whoa, you dropped. Okay, that's what the term lightning means. There's a descent where the baby's getting ready to be born. There's an increase in clear and non-irritating vaginal secretions. That's normal. That's not an infection. That's just totally normal for prior to delivery. Bloody show we just talked about. A lot of patients get energy spurts where they feel like cleaning their whole house, painting the nursery, setting up the crib, stuff like that. But that's normal right before they go into labor. And then a small weight loss is normal. Normally we're expecting them to gain throughout the pregnancy, but a small weight loss right before labor is normal too. Okay? And then Leopold's maneuvers. It's just good to be familiar with what this is. When a patient comes in and we're going to palpate where to place the fetal monitor, it's an external monitor, we're going to start at the top, at the fundus, and palpate and try to figure out, hopefully that is a little baby's bottom right there, not a baby's head, but we're going to try to find the back. We're looking for this because we're going to be placing our monitor right around this club, right behind the baby's back to get the heart rate. So that's the first part of a Leopold's. Second, she's determining, okay, this is the back, and she's going to follow it down. Please do this with your nurse if you can. And what Regina was saying is you can come to that birthing center and you could practice Leopold's on their patients. So I would take her up on that if you can, where patients don't mind. And then where on the outside you can kind of feel the head wedged down into the pelvis. That's the next thing we're doing. And then again, we have our head there, and we're going to be placing our monitor right there. The best place to pick up the heart rate is through the baby's back. When you try to monitor it through the abdomen to the front, it usually doesn't pick up very well. So please do that with your nurse if you're going to L&D. Help her put the monitor on. That's something you can help her do, and it's fun. And the patient likes hearing the baby's heart rate. We all do. These are conditions associated with fetal compromise, and we'll get way more into this with our other PowerPoints. But when the fetal heart rate is below the norm, which is 110, or the fetal heart rate is above the 160 mark, both of these are not good signs. So not that they have to have a C-section right away, but we want to try to figure out what's going on with this baby, why they're having abnormalities in the heart rate. And then little or no variability. There's been a few times in my L&D career where when I put a patient on a monitor, there's no variability in the heart rate. It's a straight line. And I know this baby's a stillborn. What happens with a lot of stillborns is the placenta is still providing blood to them, but the baby, for some reason, we've lost the baby. So you're picking up this heart rate, but there's no fluctuation. And it's just the worst feeling as an L&D nurse to pick that up. It's horrible. Persistent slowing of heart rate after the contractions, that's known as late deceleration. So right on your PowerPoint, late deceleration, That's the one type of deceleration where we are going to, as nurses, act on that. That's a sign of decreased placental function and supplying oxygenation to the baby. Okay, and then neck-stained fluid, we talked about that a little bit yesterday. That's when the babies had a bowel movement. Babies have bowel movements in the amniotic sac because for some reason the cord has become compressed. When the cord becomes compressed, it reduces blood flow to the baby and causes the anal sphincter to relax, and that's why they have this meconium cast. So we know that there's been something that's happened to this baby to cause for them to have a meconium in the fluid. So once there's a meconium-stained fluid, we're going to watch this mom and baby very, very carefully because something has happened to cause, the cord to have basically a cord accident. Cloudy, yellowish, or foul color to amniotic fluid. If a patient is developing chorioamnionitis, that's something you need to write down, chorioamnionitis. That means there is now an infection in the water bag. These infections in the water bag are really, really dangerous to the mother and to the baby. So if we are smelling a foul odor, what we're gonna do at that point is get cultures. We'll get anaerobic cultures and aerobic cultures immediately. We'll get our provider, our doctor, or midwife alerted to this, and they'll go on probably triple antibiotics while they're in labor. We're gonna do everything we can to kill this germ. But we want to get the cultures first, because what if we don't get the cultures first and we give the antibiotics? Yeah, we could be giving the wrong antibiotic that's not effective. So it's always important, no matter what type of infection is going on in your patient, that you get cultures first, okay? Otherwise, the antibiotic administration is going to mask everything, and you're not going to really get to know. Okay, contractions that last longer than 90 seconds, that's hyperstimulation of the uterus. We don't want to let that go on because when the uterus is contracting, it's squeezing on the placenta. And the placenta is what is supplying the baby with oxygen. So when you have super long contractions, that's going to affect oxygenation to the baby. Okay, we don't ignore that. Incomplete uterine relaxation. In between contractions, there should be a nice lull so that there is complete relaxation of the uterine muscle so that good oxygenation can take place for the baby. So we don't want contractions any closer than 2 minutes apart. And it's preferable 2 to 3. And hopefully they're, at least they should be 60 seconds. Good contractions are 60 to 80 seconds long. And then a nice relaxation in between. Maternal hypotension is something we need to address immediately. If we don't, the baby will end up having a big bradycardia in the heart rate. And once that happens, people freak out. They're going to want to do a stat C-section. When we insert epidurals in patients, very commonly, they have a big drop in the blood pressure. So we want to correct that immediately. Yeah, if we don't, there's going to be a big bradycardia. And it can all be avoided if we give mom ephedrine immediately. Ephedrine is a drug you're going to need to know, but I'll get more into that. Maternal hypertension is another thing we need to take care of. Otherwise, what do you think that does to the fetus if mom has raging hypertension? What does that do to the baby? Stress them out, but what it causes them is to be undergrown infants, IUGR, intrauterine growth restriction, because with mom's vascular system constricted, we're reducing the amount of oxygen getting to the fetus. So we want to correct maternal hypotension and hypertension, both. And then maternal fever. If we don't address mom's fever, we're going to end up with a very septic infant. And this chorioamnionitis, it's very lethal. It's really bad for the infant. So we want to get that corrected. Any questions about those? Okay, so get your clickers ready. Because in our next PowerPoint, we're going to use them. Okay? Did anything I say not make sense? I know it's a whole different language. And we'll take our break at 3:30, okay? Because our class goes from 2:30 to 16:35, I believe. Is that all right? Okay. everybody know how to turn on their clickers? The questions are toward the end of the PowerPoint. So why don't you try to turn them on, if you can. Okay, and I'm sure there's some technologically savvy people who can help the lesser technological savvy people. Yes. It says it on the instructions, I believe. I don't have the instructions. Are there any extra copies of instructions? Let's just pick a channel. Okay, try channel 5. Are all of them coming on? Try channel 5. Yeah, let's try channel 5. Yes? Yours won't turn on? Okay. If the batteries are dead, you guys have to replace it. They're free. Yeah. Yeah, batteries are dead last semester. Does anybody else have a dead battery? Okay, well, maybe you can do it more quickly and ask me a question. Not a dead battery. You don't want it? Because you don't know the answer? Okay, let's just give it a try. Okay, we're going to start stages of labor. Did everybody read about stages of labor last night? No? Okay. Yes?
I was reading about it, but then I couldn't find the innovations for the nursing.
Find the interventions
Right.
for each stage. You're reading chapter 17? Okay. I was reading the book today, too. I love the book. I was refreshing my mind on the book. It's like a really good book. When I was a nursing student, some books were good, some were horrible. They were way too advanced for me. I'm like, what are they talking about? But I think this book is user friendly. Okay, well, we're going to talk about nursing interventions throughout this whole PowerPoint. So, and pretty much every PowerPoint I talk about nursing interventions because that's what you need to be aware of, and that's what NCLEX is all about. You know, what is the first nursing action when this is happening? Or what is the priority nursing diagnosis for this patient? Okay? So the first stage of labor is in 3 phases, and what are they? Latent. Right. So we have latent, active, and transition. And how long can the latent phase last? A long time, especially if it's your first baby. It can last for days, absolutely. And it's best to let a patient, let her go home and soak in the bathtub. We used to have a lot of suggestions for patients who are just stuck at 2 centimeters, maybe 3. But soaking in a nice hot bathtub, walking to the mall, just walk for hours, whatever. But the goal is to keep them out of the hospital until they're at least 4 centimeters, basically. Because that phase can just lag on and on and on. Sometimes we give them a sleeping pill and send them home to get some sleep. Because when the body is exhausted, it doesn't contract in a good functional way. So latent can go forever, 0 to 3. So active phase 4 to 7, and then transition 8 to 10. Transition phase on a multi can go in a matter of minutes, okay? They can go in one contraction, from 8 to 10. That's how fast that transition phase can be for somebody who's had other babies. With the primate, not so lucky. Usually it's about an hour for each centimeter. I used to tell my patients we plan on 1 hour for each centimeter, and you have to get to 10. And then once you're to 10, you're going to be pushing for a couple of hours. Okay, that's just reality with the first baby. So I would give them a really good, very clear idea of what to expect. And I believe that's really important, because some people think they're just going to come in because they've watched these TV shows where people have their baby in like 5 minutes on the show, you know, or a movie that might take 10 minutes. But you know what I mean? They have kind of preconceived ideas that are completely wrong about the reality of real labor. So in the latent phase, are we wanting to medicate a patient? We really are not. We really do not want to medicate them 0 to 3 centimeters. What are some non-pharmacological methods of reducing pain? Warm water, like getting in a bathtub? Oh, absolutely. Bathtub, showers, massage. We can teach them to do effleurage, it's called, on their own belly if they're laying on their back. We can teach their coach to massage their back, massage their feet, to help them to relax. That's the goal. If they learned breathing, we want them breathing very slow, very relaxed. We don't want any of the faster breathing. We just want slow, deep chest, they call it in Bradley, I believe. But we just want to do as much as we can non-pharmacologically. If they can get out of that bed and walk, and they feel okay walking, they need to be walking. Or sitting up in a rocking chair, but sitting upright. Because then we have gravity helping to pull the baby down. I would explain that to patients. The more you're up and moving and you have gravity working with you, instead of lying in a bed, you have gravity working against you. It's not doing anything to help get this process going. With transition, that's usually when a patient will slap somebody or cuss or threaten their husband. Yeah, they get kind of out of there, just kind of wacky acting. Or if all of a sudden the patient's whole mood changes, that's a good indication that she's getting into transition. And so we would want to check her cervix at that point. If all of a sudden she went from really controlled breathing, doing great, and now she's kind of flipping out. That's somebody going naturally. You're going to mostly see people having C-sections in our hospitals. Okay, so second stage is what? So when they're 10, and then what happens? They're going to push. Nowadays, they recommend not pushing right away. We used to push patients as soon as they became 10. Nowadays, we try to put it off for a while because they found out there's just so much maternal fatigue when they're pushing, and then the baby ends up getting less oxygen during all that pushing. So, and I was loving what the book was saying about that. You don't want them holding their breath and bearing down for more than 6 to 8 seconds. We used to try to get them to bear down for a lot longer than that. But research, evidence-based research has shown us it contributes to fatigue, it increases their chances for a C-section, so we don't want to have them bearing down for too long. Okay, so the baby's delivered at the end of second stage, and then what is third stage? We wait for the placenta. Midwives are very patient and waiting for placentas, and doctors are not. You're going to see doctors yanking and pulling down on the cord and trying to get the placenta out. You're going to see that, mark my words. You'll be like, yeah, that's what Becca said. Because they just don't want to sit there and wait. It takes usually 20 to 30 minutes for a placenta to naturally detach from the wall of the uterus. And then the patient usually kind of feels like it's like a little delivery of the placenta. But normally there's an extra trickle of bleeding that happens at that point. So if you're sitting down there at the perineum and you see an extra gush of blood, that's normal. That's a normal thing when that placenta detaches, because all those blood vessels are wide open because they've been used to, putting blood into that placenta. So then all of a sudden that pulls away, and then there's some extra bleeding, but that's normal. So you'll see an extra gush of blood as that placenta comes out. At that point, what are we doing as far as nursing care? What do you think the nurse is doing? The placenta has just come out. You want to make sure it's intact. And the doctor or the midwife should check that. If they don't have time because something else happens, it's our job to make sure that whole placenta is completely intact and document that. And then we want to start decreasing the bleeding. Okay, that's our focus. So that's when we will start massaging that fundus, and that's when we will administer Pitocin into the IV fluid. If she's been an induction of labor with Pitocin running in her IV fluid, that's when we would just open up that line. Because we want Pitocin, which is going to cause the uterus to contract. Okay, our goal is to get that uterus to contract. At the turn of the last century, like 50% of women died in childbirth. And it was due to hemorrhage, number one, or infection, second. So and in third world countries, they still lose patients to hemorrhage. We actually send these little packs now. I've looked online with a little thing of Pitocin in them, or they can just inject it into their thigh, 10 units of PIT. And these little packs that we've sent over to third world countries are highly effective in saving women's life postpartum from hemorrhage. Pretty amazing. So question? Yeah, they just manually remove it, and they actually do a really good job of making sure everything's out of there. And yeah, they just do it all manually. But you'll get to see that when you see your C-section. Yeah. What? They just kind of scoop it out. But in surgery, they can make sure they have the whole thing, and they can make sure any bleeders get stopped if they have any hemorrhage issues. Okay, so the fourth stage is the first 1 to 4 hours postpartum, and that's the most critical time. I'd say the first 2 hours are a time where you've really got to watch your patient, because patients can be doing great, and the next thing you know, they're hemorrhaging. And if a woman starts full-blown hemorrhaging, she can bleed out in about 5 minutes. So it's a time to take really seriously, but you don't want to be all anxious acting. But you want to be monitoring her blood pressure, her pulse rate, her fundus, and the lochia. The lochia is the blood that's going to come out now after the baby's out. So we're monitoring blood pressure, pulse rate, fundus, lochia every 15 minutes. Okay, if we can get her to breastfeed, that's an ideal thing to do, because the action of breastfeeding stimulates her own oxytocin to be produced within her own body, and that's going to help contract the uterus in itself. So that's one reason, if she can do it, if she's feeling up to it and she's not too fatigued, is to get the baby to latch on and breastfeed right away. So, and we want to explain that to the mom. It's really good if you can breastfeed right now. It's good for the baby, but it's really good for you, because the colostrum is really excellent for the baby's stomach and intestinal tract. Okay, so biological system needs for oxygenation. We want to assist moms with breathing, and we want to make sure they're not hyperventilating. And it's really common to have our patients hyperventilate. So what do patients complain of when they're hyperventilating? What? Yeah, lightheadedness, and what? Numbness and tingling. My hands are starting to feel tingly. And so when we hear them see that, what are we going to say? Slow your breathing down. I'm going to give you a little brown bag. Yeah, and I'm going to have you breathe in that for a couple breaths. But you're breathing too fast, and that's what's making you feel tingly. So we're going to help you to slow it down and just breathe in this bag. And they usually have little brown bags at the bedside table just for this. Okay, and it's very common for a patient to hyperventilate. Okay, so for circulation, we're going to position her on the left side to prevent what? What kind of hypotension? Supine hypotension. It's a huge issue with a pregnant person from the time they're 20 weeks pregnant on. Once the baby's big enough to be lying and weighting down those major vessels, we want mom off of her back and onto her side. Left side is preferred, but we'll have her switch from side to side. Right side is great too. If the supine hypotension does not get addressed, what kind of decelerations does it cause? Late decelerations, and put a circle around that, because we have to treat late decelerations. We've got to make them stop. Okay. We're going to note her H&H. When a patient comes in to deliver, they get a CBC drawn when they get their IV started. So we have a baseline CBC and an H&H to look at, and then after delivery, they usually recheck it again. And we will expect what? We'll expect a drop, okay? Not a big drop unless she's really hemorrhaged, but we will expect a drop, and that's normal. Okay, we're not alarmed about that. Okay, so this is just a nice picture. Oh, hi, Becky.
Hey, Becky.
How's it going?
Okay.
Come on in. Good.
Hi, everybody.
Okay, it's over here.
I know.
What is up with that?
I don't know. I don't know why it's so
I'm
loud.
sorry.
It's the hot room.
Sorry. On a more positive note, hi! Welcome to second semester!
Yay!
And the first week's almost over!
Yay! It's a holiday weekend!
Oh, it's a long week, but don't come to normal on Monday. You're on campus on
You'll
Monday.
be the only one there.
So I wanted to come by and say hi. How are things going? Any issues? Questions? Problems? Okay, next week. Okay, always open. I want to let you know a couple of things. I don't know if I had mentioned this before, but the Board of Registered Nursing is coming this semester for our site visit. And it's what the Board of Registered Nursing does every 4 years for all programs. They come out and do a site visit. And so they're going to be here on December 4th and 5th. It's a Tuesday and a Wednesday. So anyone in clinical on Tuesday, we may be invited to see you. And then on Wednesday, December 5th, there will be a first year student meeting with the Board of Registered Nursing. And you'll be talking with them, they'll be asking you questions. So we'll let you know as the semester goes along, so what kind of questions are they going to ask? What do you need to know? What are you going to do? So we'll get into that and stuff. But in preparation for that, we're going to have our mandatory general nursing assembly on October 25th. It's a Thursday. So Thursday, October 25th is the mandatory general nursing assembly where all 4 semesters get together. We do this once a year. And it's at 12 o'clock in Phillips Hall. 12 o'clock in Phillips Hall on October 25th. And again, we'll tell you more in the future and stuff like that. But I just wanted to give you a heads up. And we'll talk about the BRN and all kinds of things at the General Assembly. Phillips Hall is the theater, over like it's against Bristol. It comes up against Bristol. Pardon? By the D building, by the C building, it's that theater that's there.
Over by Gina's office, that one.
Yeah.
They all signed up.
You've been over
Gina's
to,
office.
you've been to Gina's office, so it would be right near there.
Right behind
And so
the,
that's October 25th. Then you have the dates of December 4th and 5th. And anything else? All is good. All is well. Question?
You found out that on October 25th is Caesar Tom's Day, is that a holiday?
No, it's not.
Is that?
No, it's the following week is the
30.
Caesar Chavez Day.
Yeah.
That's when that holiday is celebrated this year. But thank you. Okay. We celebrate Caesar Chavez Day, but I think it's actually, strangely enough, during spring break. And so the staff, we're here for a large part of spring break, but we actually have a day off. So we'll double check with the overview. Anything else? Any other questions? Good catch. To check on that one. Okay. Yeah.
Is someone going to come talk to us about the bridge program for the Phillips one? Or should we come to you?
I will when I hear something, because what they're having budget issues, as are all the universities, and so I am not 100% sure it's going to continue. It may even be just this one window of opportunity, and they're not going to repeat it. But I'm going to check on that and make sure what their answer is as to whether or not they can continue it next semester as well. Because that would be the time for you guys to do that for a third semester. Are you all aware of what she's talking about? That we have sort of a dual enrollment in a way, that students who are in the third semester are also taking a course towards their bachelor's degree at Cal State Fullerton. So they take a course in third, they take a course in fourth, they take a course during the summer, and then they enter into their program and they have 1 year and they're finished with their bachelor's. But we have to find out whether or not Cal State Fullerton can continue that. I know that if they don't, Concordia is very much still on the radar and able to continue. Once you graduate, obviously there are a number of universities that have an RN to BSN, one of them being Vanguard. They're another university that we're working with. And so, yeah, I'll come back. Okay, thank you. Anything else? Okay, have a good semester.
Thank you.
Thanks. Goodbye. Okay, so let's go to immune response. During first stage of labor, hand washing is the #1 most effective way to prevent the spread of germs. It's been proven, evidence-based research over and over and over again. So even though you're wearing gloves with your labor patients because of the blood and body fluid issue, you still need to wash your hands after you take off the gloves. Okay, please do that. Just get into that practice. Because these patients, when you're changing their chucks, there's tons of amniotic fluid and blood. So you want to really be thinking protect yourself. Also in the delivery room, if the water bag is to break, stay out of the vicinity of where that amniotic fluid could fly into your eyes and stuff. Because that's a potential way to get organisms into your body. You just have to be thinking prevention for your own self as a nurse, as a student. If the patient is GBS positive, GBS stands for Group B strep. Group B strep is really common in our population. At least 1/3 of all women, childbearing age, are GBS positive. It's a harmless organism to the woman, but it's a lethal organism to the newborn. And newborns will die. If mom isn't treated for GBS, and seriously, she has her symptoms. We do these cultures on the moms between 35 and 37 weeks. We do the final one. We try to do it on all patients. And then we let them know their GBS status prior to them coming into the hospital. We actually give that to them to bring their prenatal records in. But we tell the mom at that time, you'll be on antibiotics during labor to prevent transmission of Group B strep to your newborn. We did have a case when I was managing the hospital out in the high desert of a normal newborn going home with mom, and about 24 hours later, she walked into the hospital, and the baby was just so lethargic and lifeless. And we had to life flight the baby from the high desert down to Loma Linda, because that was like our brother-sister hospital. And the baby was in the NICU for 30 days, and the baby made it. And what I learned at that time, because I had come from Kaiser where we were treating everybody for GBS, and then I went to this community hospital where we weren't testing for it and we weren't doing anything for it. And then we almost lost a baby. So I did my own study as the manager, and we screened all the patients for a year, and we determined 33% of our patients are positive. And from then on, we started carrying on what Kaiser did, which is the national standard, is to treat prophylactically for GBS. So we were lucky we didn't lose that baby. What I learned after that is that GBS is just such a terrible, toxic organism to the newborn. So that's an important thing you need to be aware of. Why GBS, we test the moms and the importance of it. So IV antibiotics will be given when she's in active labor. The drug of choice is ampicillin. If she's allergic to ampicillin, we'll give her clindamycin. Ampicillin is given then every 4 hours until the baby's born. And if mom has received 2 doses of ampicillin or clindamycin, then we feel that the baby will be safe. If she's only gotten 1 dose, we'll probably still either watch the baby, observe the baby carefully, or we'll do a little septic workup on that baby. Okay, so that's an important concept to understand. As far as urinary elimination, the IV rate, does anybody, Well, if she has an epidural. Okay, with the epidurals, we're going to bolus mom with 500 to 1,000 mLs prior to the insertion of the epidural. So then we're going to be, the IV rate is going to be what? Momentarily up for the fluid bolus. And then we're going to monitor like crazy for bladder distension and most likely put the Foley catheter in. I used to tell patients I'd rather put a Foley catheter in you once than do in and out caths every 2 hours until you deliver, because that's all the more potential for them to get a UTI is every time you're inserting that catheter. So we definitely want to monitor her bladder. The other thing is with an active labor patient with no epidural, when they're in that much pain, their bladder can be filling and they're not even aware of it because they're in so much pain from the labor. So monitoring the bladder is just really, really important for all labor patients and postpartum too. So we want to encourage voiding every 2 hours, and then we're going to place an INO cath or Foley, right? Yeah, if needed. And please step up to the plate and ask your nurses. If you're an L&D, just tell them you want to do any Foleys. If they have any Foleys, just make that clear. Yes.
What do you do a bolus of right matter 1,000?
Lactated ringers is usually their IV solution. It's an isotonic solution, but they bolus them up. They're trying to prevent maternal hypotension once the epidural is in place. It works sometimes, but it doesn't always work. So that's the goal, is to expand the volume and their circulatory system to prevent maternal hypotension.
So is the epi side effect, the side effect of an epi is maternal hypotension?
It is. And really, because I go to conferences a lot and I look at the research a lot, they really feel that it's just simply when you're removing pain from somebody who's been in extreme pain, and all of a sudden they're out of pain. And you know how our body is secreting things because we're in so much pain, and then we stop the pain, and then that's when they bottom out their blood pressure. It's really due to that, not necessarily the epidural itself. So that's what some research lends itself to. The bottom line is, you're going to be monitoring her blood pressure every 5 minutes for the first 15 minutes after that epidural is in. Anesthesiologists or nurse anesthetists usually stay at the bedside for that first 15 minutes because we almost expect that. When I say bottom out, I'm saying 70 over 40. All of a sudden they drop substantially and become symptomatic. So we want to have ephedrine. It's ephedrine, that medication available and ready. And the nurse can give it if your policy permits you to, or anesthesia gives it. It's an IV push medication to get that pressure back up to normal. Okay, so nutrition, we're going to give clear liquids only. They're lucky if they get anything. We pretty much starve them to death. When you work with midwives, they actually let patients have a regular diet during labor. We're going to assist with pain relief measures. Non-pharmacological at the beginning, and then we need to talk to them at the beginning of labor to figure out what they exactly want to have. Are you thinking of an epidural? Is that something on the radar for you? Or you just want to have IV pain meds, or you just want to go natural? We need to get that out of them at the beginning, because if not, and then that extreme pain starts hitting them in the active phase, we just want them to know, what's available and what they could ask for. We just want to do it early, because once they're in extreme pain, it's really hard to talk. If you've ever been in labor, you know what I'm talking about. You need to have pre-decided what your options are and what your number one choices are. Okay, so if you are helping with that regional, you're going to be helping with positioning that patient. It's really important when an epidural goes in that the patient not move. And that's our job as the nurse assisting, is to make sure we hold the patient, talk to them, explain the importance of not moving when that needle that's this long. Hopefully you guys will get to see an epidural place, but they need to not move. It's really important. What? Okay, skin integrity. We're going to monitor the IV site. We'll talk a lot more about that with IV therapy. And we want to keep their perineal area cleansed, because there's a lot of blood and body fluids, and there could possibly be feces. They used to give enemas to everybody when they first came in labor, and they stopped doing that. So I just tell patients, if you haven't had a bowel movement, I would take a little fleece enema, because otherwise, when they start pushing, they're going to have feces. we just want to keep that area clean. Okay, so ambulation if possible. We want them up walking. Once they're ruptured bag of water, they usually aren't allowed to walk. And once the epidural is in, what kind of activity is ordered? Bed rests. They'll be on bed rests, yeah. So keeping them moving is really good for their circulation system. So we're monitoring the heart rate, fetal heart rate, and the contraction pattern every 30 minutes. We're charting that every 30 minutes. We're palpating the contractions. Where do we palpate contractions? On the fundus. Fundus should be one of your normal words of your vocabulary for the next 8 weeks. We're going to note if there's accelerations, decelerations, and we're always going to be noting the variability in the heart rate. We're going to be charting all that every 30 minutes. We're going to note the color of the amniotic fluid when their water breaks. If it's meconium, we will alert the NICU team and just call them and let them know what room our patient's in and that we have a meconium delivery coming up at some point. But we want everybody to know in our unit when we have a patient that has meconium fluid, because you never know who's going to end up in that delivery room. And we need to know ahead of time what's going to be a mech delivery, because we're going to have extra suction equipment available. Maybe our little ET tube tray all set up and ready to go. So that's just important. And then Pitocin augmentation is an IV drip where we will facilitate their contractions and get them into really strong labor. And this is just a picture of breaking the bag of water from your book. And the hook, it's amni hook, it looks like a crochet hook if you've ever knitted or crocheted. And it doesn't cause any pain to the mom. Okay, so let's take a break right now and come back in 10 minutes. Okay? Yeah, it's pretty hot in here. It's lovely. It's like blazing. Okay, good. What's that? Oh, it's ridiculous. But tomorrow it's going to be really good.
My brother said it was trying, but he's the eternal optimist.
Oh, yeah?
He's one of those that...
I had it on in my office. I was watching Southside of the Pier. But tomorrow. Yeah, that's awesome. Okay? Oh, thanks.
But
I'll give that to Gina.
I just don't know what I'm gonna bring. I know that I'm gonna bring my stethoscope for blood pressure and monitor.
Oh, yeah. You just need to bring your stethoscope. Channel 41 for the clickers. Oh, Dale. He's my lifeline. Okay, so channel 41 for the clickers. And we're going to keep going. Just because, yeah, 41 is our channel. Okay, so intellectual process for first stage of labor. We want to assess knowledge during the very beginning when they walk in. And normally we would ask patients, and we'd have little boxes to check off. How do you best learn? Do you best learn from reading, from videos, from demonstration? Tell us how you best learn, because we're going to be teaching that patient all about how to care for their babies for the next couple of days after they have their baby. So, and we want to assess how much they know about childbirth. Some patients come in and they've read every book and every library, everything. They just know so much information. Other patients come in, they haven't read anything. They're too busy. They don't have time. So we're going to be, depending on how much they've learned and how much they know, we're going to gear what we're teaching them according to their background. Okay? So we teach small amounts of information in between contractions. That's our goal. Because if you're talking to somebody who's ever been in labor during a contraction, the last thing they need to be doing is trying to comprehend anything. We want them breathing through and just focusing on their focal point. Okay, so then as far as procedures during labor, we want to be explaining everything that's going to happen. We want to explain We're checking your cervix right now to see where you're at, and then throughout labor, we'll recheck you as deemed appropriate. We're not necessarily going to check you every 2 hours. We might check you every 4 hours. We might just check you just when we think you need it. We try to avoid, especially after the water bag break, vag exams because of the potential of introducing infection into the uterus. So we really reduce the number of vag exams after they're ruptured. So anyway, okay, so we really want them to have a significant other with them. Some patients get dropped off at the hospital and their husband has to go to work, and that's all she wrote. Like, well, can't we get your sister, your mom, your whoever? And so, yeah, I've spent some time with patients that are all by themselves because I feel really sorry for them. We want to explain procedures and terminology that they can understand. We're not going to be saying things like, oh, the doctor's going to come in and do a vagogram. We're going to tell our patient what? The doctor's going to come in and check your cervix and to see how far dilated you are. We might put some monitors to monitor the baby. I mean, we bring this down to about a 6th grade level. We make it really simple because we don't want to talk. Many doctors come in and they talk up here and the patient's down here. And then the doctor leaves, and I'll say, okay, I'm going to explain to you what you just said in regular words. Like I feel like I used to interpret for doctors all the time in layman's terms, so the patients can get what's going on. Okay, so that's really important. We want her to be able to express her feelings. Some patients are going through a lot. Some people are completely freaked out and scared to death, and we want them to at least express what's going on so we can help alleviate fears, frustration, anxiety. And then we're going to monitor them for behavior changes. Because when behavior changes during labor, it usually means they're getting really active labor. And that's a good sign. Okay, so 2nd stage, we're going to assist them with pushing, bearing down efforts. We're going to assist them into a good position for pushing. But they can push in sideline position. If we're having trouble with the fetal heart rate, not having enough oxygenation to the baby, we'll have her push on her side, which promotes oxygenation to the baby. With the midwives, we used to actually have patients squat to help them get into the idea of you need to be using these muscles to get this baby out. Midwives are really good about doing whatever works. Okay, so neurologically, sometimes the continuous epidural infusion of medication may be what? When she's in 2nd stage. Yeah, slow down the rate because we want what to happen. We want her to be able to feel a little bit more pressure so she can push with that. So some providers just say turn off the epidural as soon as she's 10 centimeters. Others, the midwives are more conducive to just bringing it down, maybe dropping the rate in half. But we want them to be feeling what they're pushing with. Okay? If they had a Foley during labor, we normally discontinue them. Although at Fountain Valley, what I've noticed, they're deflating the bulb, but they're leaving the Foley in. And I don't know if they're doing that according to evidence-based research. I haven't had the opportunity to question them about that, but I don't really like it because I'm afraid for damage to take place of that pushing. Anyway, but let me know what you see, okay, in your hospitals. Let me see if they're de-seeing the Foley when they start pushing or if they're just deflating the bulb. And we want to keep the rectal area clean. That's really important when they're pushing. If they have an episiotomy, that's done right before the baby comes out. How many of you had episiotomies or saw them with the deliveries you assisted? It's a big cut in the perineum, the head's crowning, and they'll cut. And my husband still's like, I hate that snipping sound. It freaks him out. But anyway, it's just a cut. The patient really doesn't feel it, whether they have an epidural or not. They usually will have their local anesthesia by that time or their pudendal block. So it just helps give more room for the baby to come out. Okay, so breathing, so 3rd stage, we want them, a lot of patients are so, from pushing and delivering the baby, they're still breathing all crazy, so 3rd stage of labor, we just want to tell them, okay, breathe slow now, if they're, still breathing kind of fast. We just want to help them slow down your breathing now. Baby's out, the son is out, or the son is going to come out. And we want to note for any shortness of breath, SOB, tachypnea, signs of respiratory distress. The gush of blood I've already mentioned as the placenta separates. That's normal. We anticipate that. And then we're going to monitor, if the bleeding is increased, we're monitoring what? Yes. And pulse rate, yes. Very good. Okay, IV rate will increase at this time in the third stage to counteract the blood loss. So, what's the name of the medication? I've already mentioned it. That's going to be in the IV fluid. Pitocin. And that's a medication you need to know for this semester, for these 8 weeks. The bladder may become distended with the increased amount of IV fluid over the labor, so we're going to keep a close eye on that bladder. You know, patients postpartum, and some of our students have come on to postpartum unit and gone in to check their patient with their nurse, and their bladders are so distended. This is after they have the baby, where their bladders are like 1,000 to 1,200 mLs of urine in them. And the potential for a bladder to rupture is really great because the patient has a decreased sensation, they're uncomfortable, they're in pain after they deliver. So I can't express enough, if you're on mother baby unit on your first rotation, when you come in the morning and you go check those patients, please assess their bladders and make sure those bladders are okay. Okay, because we don't want a ruptured, I've heard stories about ruptured bladders. It does happen. The fundus will be massaging that every 15 minutes. We massage and release. We massage the fundus and release. We don't ever do a continuous massaging, because if you continuously just keep massaging it, it actually has the opposite effect, and it becomes it gets softer. Okay, so just remember that. We want to firm it up, and release. Okay, we don't want to continuously massage the fundus ever. And what are we noting on the fundus? The what? The firmness, so the tone, we call that the tone. And then what else are we going to chart? The location, so the position. So we're looking for the position and the tone. And by position, we mean the position in relation to the umbilicus. We're going to palpate it. It should be right at the umbilicus. If the fundus is 1 finger breadth above the umbilicus, 2 finger breadths above the umbilicus, that's how we're going to chart it. If it's high and to the right, that's usually an indication that the bladder's full. So we would chart that, and then we would try to get her to empty that bladder. Okay? Methergin is a medication that if the Pitocin we're giving IV is not controlling bleeding, Methergin is the next medication you need to know. You need to know that this is going to be the med. It's an IM medication that we're going to get drawn up and give it to her, usually in her thigh. The dosage is 0.2 milligrams. What side effect do we know that Methergin has? Anybody read that? Methergin can cause high blood pressure. So prior to giving Methergin, we're going to make sure we know what her blood pressure is. And a good physician, a good midwife will say, what's her blood pressure before you give her the Methergin? They'll ask you that. And you should know that off the top of your head. If she has high blood pressure, we won't give Methergin. Okay? And then the psychosocial needs, we want to monitor if she's ready to bond with the baby and attach with the baby. Some patients are so exhausted from their laboring experience that they can't even fathom thinking about holding their baby yet, because they're completely exhausted to the max. So we don't want to force them to hold the baby. We can always have the father of the baby hold the baby and bond with the baby. But we want to see how she's doing and talk to her and ask her. Okay, and then fourth stage of labor, we're monitoring respiratory effort Q15 in addition to blood pressure and pulse. And for C-section patients, it'll be Q15 probably for 2 hours or longer. With patients who've had the epidural, we're going to keep a closer eye on their respirations for about 24 hours, because the Duramorph has a long-acting effect on the respiratory center. So we want to we usually keep a pulse oximeter on those patients for 24 hours if they've had Duramorph in their epidural. Okay, that's important. Write that down. Monitor BP and pulse Q15 for a minimum of 1 hour. So what would indicate bleeding? What change in vital signs? Increased pulse rate, and what kind of blood pressure? Decreasing. So if we see a dropping blood pressure or an increased heart rate, or either one, or just one of those, we want to keep a close eye on that. Okay. If they're a vag delivery, can they have food after they deliver? What kind of diet? What? For vag delivery, not clear. We torture them during labor with clear liquid. They actually have regular food, and we tell them go home and get them whatever they want. Go buy them something they can actually eat after a vag delivery. C-section, they will advance from NPO to ice chips to clear. And we'll be listening to bowel sounds, right? This is a surgery patient. So we don't want to give them any fluids right off the bat, any post-op C-section, even though they're saying, oh, my mouth is so dry, I'm so thirsty. Because when we do that, they can potentially vomit. And the last thing we want is our post-op C-section vomiting on top of her regular recovery that's happening. So we advance as they can handle it. We're monitoring level of consciousness along with those vital signs every 15 minutes. Depending on the level of their epidural, of the anesthesia, we want to check the level. Okay, so we would be charting that as well. We're monitoring their sensory and motor movement. So with the epidurals, some of them wear off really nicely, really quickly, and some linger on. We have to be really careful when we get them up to ambulate them after they've had the epidural, because some patients are like, yeah, I can move my feet, I can feel my legs, I'm fine, and then you stand them at the bedside, and their knees buckle. And so it's really important to have two people to get them up the very first time when they're going to ambulate after delivery. And the patient will continue to receive IV fluids and wet to control postpartum bleeding. That's the Pitocin. Usually they'll have one more bag of fluid that hangs after the delivery with Pitocin in it. That's normal. And then that'll be deceived as long as they're bleeding a small amount. And we're monitoring for wet bladder, distended bladder, and if they can get up to the bathroom, we want to get them up and ambulate them to the bathroom if they can. Okay, fluids and fiber will help with constipation. The progesterone that's produced in the body during pregnancy can cause them to be constipated postpartum. And also, a lot of patients have to take iron. They have to, we don't give them any food during labor. And then all these can cause constipation. Monitor for swelling of the perineum. What do you think we're going to apply to the perineum for the first 24 hours? Ice packs. And we should put ice on them immediately as soon as the delivery is all done and they're all stitched. If they have stitches, put an ice pack on their perineum and keep a lot of ice on for that first 24 hours. And then we want them up. Why do you want to get patients up after they've delivered so badly?
Decrease complications of clots.
Yes, it's going to decrease the potential complication of blood clots. So we want to get their circulatory system moving. That's our number one goal in getting them out of bed and getting them to walk to the bathroom. Okay, and then we encourage rest to reduce stress. We encourage them to rest when the baby rests. Okay, and we tell them when you go home, don't plan to do a bunch of housework. Take care of the baby, take care of you, get rest, like, get up and not overdo it. With the C-section, you'll have to stay in bed for 12 hours. We want them doing leg exercises. We want those compression stockings on their legs. It's really important. Okay, and monitor, we've already talked about this, the tone and the position of the uterus. Tone and position, we're charting that. If the uterus is displaced to the right or the left, the bladder could be full. So we want to get that bladder empty. The full bladder can promote bleeding. The full bladder in the laboring patient can hold the baby's head up. That full bladder can cause a lot of problems. So we want to make sure that the bladder stays empty. We're going to check the breast, note if soft or firm. Look for any cracks in the nipple. That could be a portal of entry for infection. And we want to assist the patient with breastfeeding and fostering attachment. If the patient does not want to see the baby at all, we're going to document that, and we're going to do a social services referral. It's not normal. There's something going on there. We want to help her figure out what's going on. The taking in phase, you need to circle that, read that in the book. Taking in phase is when mom is taking in care for herself. It's not a time that she wants to take care of the baby or can learn how to take care of her baby. Okay, the taking hold phase is when she can actually start, okay, I want to hold the baby. Can you show me how to breastfeed? That's when they're ready to learn something. So patients go through these phases at different lengths of time. Some patients are ready to start learning right away. Others are just like, they've been through a lot and they just need their own time to regroup and recover. We're going to be teaching Mom self-care needs, about how to take care of her postpartum issues, and then she's going to be learning about the baby care as well. So Mom is learning a lot in the next 48 hours. Okay, so get your clickers out. Let's see if we can do this. Here's our first question. Let me see. Oh, great. It says pulling open. Oh, good. It's working. Go ahead and I have 3 responses. So first stage of labor is described as, look at those answers and choose. Yeah, it's open. I have 5 responses. So it's channel 41. I'm excited. It's working. Yay! 41? Yeah, channel 41. We have 11 responses. 14, 15. Good job, you guys. Is everybody getting their clickers to work? Except for the dead battery? 27. Can't get it? Somebody help her. 28. Anybody still trying to? It's not working.
It is on.
Or channel 41? Okay, who can help her? Okay. Yeah, I don't know. Who around her did theirs work good? Okay, I have 29 responses. Raise your hand if you're having trouble.
It says no for waiter.
Is yours working?
So you just press number and then press that?
Yeah. 29 responses. That's pretty good out of 35. Or 1 absent person. User feedback 2. Okay. Okay, everybody got it? Kind of? Okay, let's go to the answer. Ready? Wait. Alright, how do I get? User feedback. Oh, there. Oh, good. 97% of you got it right. Yay! Bravo, bravo, bravo. Okay. All right, let's go to the next one. Okay, there's your answer. Okay, the laboring patient with prolonged rupture of membranes. And there's your 3 answers. Is likely to have a dry birth. Will have increased pain. Difficulty voiding. Will have increased chance for infection. Pulling is open. Everybody have your clickers? Two responses. 24. 26. 27. 27. Anybody else trying to vote? Or trying to choose? 29. Oh, yay. Is that it? I think that's all that voted last time. Oh, 30. Ooh, 30. Anybody else trying to vote? Everybody good? Okay. There it is. That's good. 83% put we'll have increased chance for infection, and that's our huge issue with prolonged rupture of membrane. Prolonged is over 12 hours. Okay? The dry birth, that's a wives' tale that we actually will have a dry birth, and a lot of that's been passed down through the families forever. That amniotic fluid is constantly reproducing itself. It's literally impossible to have a dry birth. There's so much fluid there. We'll have increased pain. There's really no connection with increased pain and prolonged rupture. Okay, good job. Yay. Okay, next one. Assessing for blank is a priority in the active labor patient. Okay, so I'm talking priority. What's the number one priority in an active labor patient? So you've got to be thinking, what does active mean? Okay, we went over the phases. There's 3 phases. She's in the active phase of labor. Okay, a few more seconds. Pressure's on. Is it bladder distension, bleeding, pain, or childbirth preparation? 23 responses. 25. 26. All right, is everybody good? Okay, we're going to go for it. Okay, look at this. 44% said pain, 41% said bleeding, and 7 and 7 for bladder distensions. Okay, so the number one priority in an active labor, a patient who is 4 to 7 centimeters. Who said pain? Raise your hand. Why'd you say pain? Because of where she is, she's 4 to 7 centimeters. This is when we're looking at managing her pain, because this is when it's intensifying, and this is when we can intervene. Okay, this is when she can get the epidural, this is when she can get narcotics, because she's not in transition yet. So pain is your number one priority. Nursing diagnosis on every labor patient. Bleeding, our labor patients should not be bleeding, okay? You know, just an active labor patient should not be bleeding, okay? And the majority of active labor patients aren't bleeding, okay? That's a huge, well, we'll get into that when we get into Module 4. The reasons why patients might be a bleeder. But so your number one priority is pain. We're going to be assessing that bladder. That's not a number one priority, that's a secondary priority. Q2 hours will assess the bladder, because a full bladder in a laboring patient can hold the head up and actually stop progress. It can stop the descent from happening. And childbirth preparation, hopefully we were assessing that in the latent phase to find out what she actually had prepared. Okay, good job. Okay, during the 4th stage of labor, the nurse's priority will be to monitor. 1, hemodynamic changes. 2, blood pressure and pulse, keep 15 minutes. 3, bladder distension. 4, bonding. Two responses. Don't be shy, don't be shy. Okay, 26, 27. Come on, just guess. If you're not sure, just guess. 29. Okay. 30. Okay, good. Okay, this is great. What's the definition of hemodynamic changes? Changes in blood volume. I just read your list. So what happens with changes in blood volume? What are we all, what's all being monitored here? What? Blood pressure, heart rate. Fundus, yes, and lochia. So we're checking to see if this fundus is firm. We're expressing out how much lochia, and we're watching how much blood she's losing. Plus, we're looking at the blood pressure and the pulse rate at the same time. We're looking at everything. We're also looking at her color. If our patient is turning pasty white, and all of a sudden, she's hemorrhaging, you know what I mean? We're looking at the whole package. So yes, BP and pulse rate, we're checking that Q15. But of these choices, hemodynamic changes encompasses all of it. So I put this one in here just to see how you guys would do, just to kind of make you think, okay? We are concerned about her bladder. We're definitely still concerned about her bladder, but that's not the priority right now. We're concerned about losing this patient to hemorrhage. Okay, that's our priority, that first 1 to 2 hours. And bonding, we care about bonding too, but that's not the priority. Okay? Good job. Okay, that's it. Wasn't that so fun?
You do that on your exam questions?
What?
When you give an obvious answer.
Usually on NCLEX questions, similar to our exam questions, there's usually 2 good answers. And so you want to take it down to the 2 best answers, and then you want to go, okay, but which one of these 2 is the best answer? And that's exactly how NCLEX is, and how RN tests, exams are. Okay, so now let's go to Okay, we're going to move on to care of the intrapartum patient. We've got some clicker questions at the end of this. And I'm going to go pretty fast so we can get to the clicker questions. Okay, so caring for our intrapartum patient, looking at oxygenation. As the level of this fundus rises, and anybody who's been pregnant can attest to it, the diaphragm pushes up, right? When you get all the way to that final trimester, I don't know how many of you actually would push the baby down and take a breath, because the baby gets wedged up under your diaphragm, and it gets much more difficult to get a good deep breath. So we want to keep the head of the bed up at least 30 degrees to facilitate oxygenation as our nursing action. Maternal blood volume increases by about 50% during pregnancy. We'll cover that in Module 4. But at that first trimester, all of a sudden the blood volume starts increasing. Our patients tend to be anemic at that time. It's a false state of anemia because the volume is increasing. So by the time we get to the 3rd trimester, and that's why patients are glowing and their hair grows and their nails are strong, because they have all this extra blood supply. So again, we go back to this whole issue with the supine hypotension. We want to make sure she's positioned correctly. We never want a pregnant patient past 20 weeks lying on their back. We want them with a tilt. So if a patient insists on lying on their back, we'll put a tilt, either a pillow or a blanket, and just get this tilt so there's a break, so we're not compressing. Even on the OR table for the C-sections, they put a tilt in there on those C-section patients to get them so they're not completely flat. The supine hypotension leads to late deceleration. So we're going to keep her positioned to the one side or the other, head of bed up. Keep that in your mind. Okay. Immune system, bag of water, we just talked about that. If it's once it's ruptured, potential for infection is constant. The longer they're ruptured, the more potential she is to get infected. So we're going to keep a closer eye on the maternal temp. From the time she ruptures, we'll be doing hourly temperatures. Up until they rupture, we don't worry so much about the temperature. But once they rupture, we're doing an hourly temperature to making sure her temp stays stable. Okay. Okay, here's the first question. Clickers out. The L&D nurse should position a labor patient with head of bed raised. And there's 4 choices. Everybody should get this right. Okay, come on, everybody should get this right. People. 27, 28, 29, and last person. Yay! Good job, class. You listened. Okay, so after the rupture of membranes, maternal temp should be a minimum assessed Q2 hours. Usually at Kaiser we did it every hour. Hand washing, most important thing you can ever do in the hospital, wash your hands even when you're using gloves. If mother ruptures membranes prior to the onset and they call us up and they say, I'm leaking fluid, we want them to get in as soon as possible. We're not going to check their cervix when they come in usually. We're only going to check their cervix once they start laboring. We do very little exams once they're ruptured. There's increase in sensible loss of fluid through exercises and breathing. So their fluid and electrolyte balance is really affected. If they're huffing and puffing a lot and they're going natural, that has a huge impact. We like to have an IV running in all of our 3 facilities. And it's important that you know it's an isotonic solution. It's LR. That'll make more sense when we get to the IV module. And it's at 125 mLs per hour, which is the average IV solution rate for an adult patient. Okay, you should know that. Once the epidural goes in, we're going to give her extra bolus of fluid. And then we're going to be assessing that bladder every 2 hours. And if she doesn't have an epidural, we'll get her up to the bathroom. It's great to get labor patients up to the bathroom, walking around. And then we'll put the Foley in if she has that epidural. And we're doing strict INO once they have an IV. Okay. Neurosensory, depending on the med she's going to get, we're going to see which systems are affected. If she gets the epidural, it will be sensory and motor functions are affected. Again, it masks the urge to void, so she won't be able to feel that. And the drug Duromorph is a great medication, and it actually lasts for 24 hours after delivery. So they need way less pain medications after delivery if they've had that Duromorph. Again, you want 2 people to help a patient up to the bathroom the first time. If you don't do that, guarantee they're going to pass out on you. You're going to be by yourself, and it's a horrible feeling. So, yeah. And if they can't get up to the bathroom, a bedpan is great. If we can avoid cathing them, that's what we want to do. We don't just want to automatically cath our patients. We want to monitor the respiratory rate for a minimum of 12 hours if they've had the Duromorph, which they'll have an O2 sat monitor. And we'll assess their pain accordingly. Okay, next question. When palpating uterine contractions, the nurse should. Clickers out. And everybody should get this if you were paying attention. If you weren't in La La Land. Okay, 17, 18, 20. Keep voting, keep voting. Anybody else voting? Guys are lagging. 26. Okay, I'm going to go for it. Oh, good job. Fingertips. Okay, 93%. Yeah, we're going to be using fingertips, okay, to palpate the contractions. When we're rubbing the fundus after delivery, that's when we're using the palm of our hands. But to palpate the laboring patient's contraction, it's fingertips. Please do that with your nose. Okay, when caring for a laboring patient who is in active phase, managing the patients, what is the priority? Everybody better get this right. I'm trying to drill this into your head. Can you tell? Okay, 22 responses. 26. Oh, yes, that's good. Yay! You got it. Okay, so INO is important. Their coach is important. We want to make sure the significant other isn't going to pass out. Their blood pressure is important too, but what's the most important is pain. Okay, to aid in maternal oxygenation. You better get this right. Let's go. Three, 25, 26, 27. Okay, that's good. Yay! Almost 100%. Okay, good. We want to raise the head of the bed. Okay, super important. And we want to tell them that. Once they're an antepartum patient coming into the clinic, we want to tell them to sleep like that. Okay, that starts way back when they're coming into the third trimester. Okay, so the 4 P's or components of the birthing process include, we covered this yesterday. Okay? So let's see who remembers. Yay, we're getting more respondents this one. Oh, 30. Okay. I think that's it. Okay. Oh, we have a split. Let's see what's correct. So it's number 3. Powers, passageway, passenger, and psyche. Okay. Prayer, I thought prayers are good too. And position, that's important too. But the actual 4 that are the correct answer is number 3. You just look back from yesterday. Okay. Okay, which factor ensures the smallest diameter of the fetal head enters the pelvis? Is it station, descent, engagement, or flexion? We covered that yesterday. Which factor ensures the smallest diameter of the fetal head to enter the pelvis? Station, descent, engagement, or flexion? We're almost there. Who's holding out? Just go for it. Just pick anything. 29. Okay. I'm going for it. Okay. Ooh, this is all over the place. Okay, so it's flexion. Remember when I was showing you, actually I showed on the diagram, chin to chest. When the baby's like that, it's the smallest diameter of the head will enter. Station is actually just the baby coming through the pelvis. Descent is actually the movement of the baby coming through. And engagement means it's just the baby's at the ischial spine. But the factor that makes sure it's the smallest is flexion. Okay? Does that ring a bell? The MD notes that the patient is 7 centimeters dilated and 100% effaced. This phase of labor is, better all get this right, latent, active, transition, or second? 26, 27, 28, 30. Yay! Active phase. Good job. What maternal factor may affect fetal descent? Decreased peristalsis, a full bladder, reduction in internal uterine size, rupture of the membrane. Okay, so I've said it a few times, a full bladder can actually hold the baby's head up and prevent it from coming down and descending into the pelvis. So during labor, keeping that bladder empty is extremely important. Okay? Okay, a woman in active labor says the water just broke. The first nursing action would be, my water just broke. Click. 1, changing the pad under her to keep her dry and comfortable. 2, assessing the fetal heart rate for 1 minute. 3, assessing maternal vital signs. 4, notifying the nurse midwife. Responses. 2 more people. Just guess. 29. 30. Okay. Oh, awesome. I love this. It's all over the place. Okay, you can't quite see it. It's number 2, assessing the fetal heart rate for 1 minute. Why is that your number 1 nursing action after her water breaks? 33% of you got it right. If you put that, why did you put that? Not necessarily. When the water breaks, the potential for the cord to get compressed, because now she's lost some water, the head's probably come down, the potential for the cord to get compressed and the baby to go into fetal distress is actually very great. Okay, so the number 1 thing we're going to do, get in there, get a nice monitor, and make sure this baby is in no fetal distress. Okay? If she's up walking and she's in the hallway and she goes, oh, my water just broke. Usually we'll put a pad on them just in case when we have them walk in the hallway. First thing we're going to do, we're going to get her back to bed without freaking her out and get her on the monitor just to make sure there's been no what's called a cord accident, where the cord hasn't become compressed. Okay, that's an emergency C-section situation when that happens. So, are we going to change her pad? Absolutely. We want to keep her dry. We do want to do that. Are we going to assess vital signs? Not necessarily. We don't really have to worry about her vital signs at that point. But we will notify the midwife or the doctor and let them know she just had a spontaneous rupture of membranes. We're going to note the color of the fluid. Is it clear fluid or is it meconium-stained fluid? Okay, so this is a really important thing to be thinking when the water breaks. If they're calling in from home, oh, my water broke, we want them in as soon as possible. We're only going to be able to determine that by getting them in.
If 3 on that it said assess fetal vital signs, would that have been the better answer?
Assess the fetal heart rate, yeah. Because really the fetal vital signs we assess is that the heart rate. So yes. We want to assess the well-being of that baby right then. Okay, does that make sense? Awesome. All right, good job. Okay, make sure you do your vocabulary for Wednesday, and then we'll have a quiz. Okay? This will be our first fun-filled quiz. And have a really good weekend. Because we have a holiday. Yay! And then Gina's group, have a great clinical day.
Yeah, we were told to tell you guys we're privileged. We get 10 extra clinicals.
Yeah. Who's going into L&D of Gina's group? Who else is going into L&D? Okay, I want you to have the best day of your life ever. Okay, promise? If you feel nervous, just tell Gina. She's very calming. Gina's my mentor. Like, I love Gina. She's like the best person ever. So, yeah, she'll calm you down. She's so sweet. And then if you're in my clinical group, please come up here and get the newborn flow sheet. Okay, bye. Okay, you too. I'm so happy the clickers work. This is the first time clickers have worked in this room for me. Because I had to bring my own computer though. But yeah, we had so much trouble with this computer last year. Did you feel like the clickers helped? When the clicker question? Did you like it? They're going to be on the exam. Yes. I'll be them all now. No, they won't be on the exam. But there'll be questions like that one. Yeah, that's good. I would write them down too. Bye. Have a good weekend. Okay, you too. Bye-bye.
Off to the kitchen.
Oh, you are?
I worked by 12 and a half.
Oh my gosh, have a good night.
Yes, thank you. No rest for the wicked.
Oh, that's true.
Have a great weekend,
Okay,
Professor.
you too.
Bye.